Alana. Welcome to the Brush with Britt podcast. Thank you so much for joining me today. I'm so excited to have you here.
Hey Britt, I'm so excited to be here too. Thanks for having me.
I have been really curious about this role that you have held, and I'm excited just to kind of chit chat about it and learn more about it. There's a lot of things going on in the dental world, and one of them being there's not enough hygienists. And so there have been different avenues that have been looked at to being adopted. And one of them that has been brought up is adopting the way dental hygiene is in the military. I tried to find information on it. I mean, I was like looking for things years ago too when I first graduated, and it was really tough to find info out there. And so when I saw you on TikTok talking about it, and then, you just wrote an article about your role, I thought it would be a really good idea just to have you on to kind of dive into what this position looked like when you held it. And I obviously don't want to say it wrong. So I'm reading this an Army Preventive Dentistry Specialist. I don't know why that's a mouthful for me. But that's the title that I saw in your article, and I would love if you would just kind of share what that role was like for you and kind of like what your scope of practice was like.
Yes, absolutely. I will also preface even getting cited sources for my article was even difficult. A lot of it was based off of my actual experience, and I was able to post like the course catalog, but essentially a preventive dentistry specialist in the Army. It is a 12-week long training program, and the main prerequisite is just to be a trained dental specialist or a dental assistant. And then, of course, on the military side, you have to meet certain physical standards, height and weight standards, which that doesn't apply in the civilian sector at all. And of course, to be a registered dental hygienist, you have to attend a CODA accredited program, pass your boards, the NBDHE, a clinical board, and then you have to have your state license. And in the military, they do hire civilian dental hygienists, but there's not enough to serve the patient population need. So the preventive dentistry specialty was one of those programs that were created to offset that. And essentially, what the role is for a preventive dentistry specialist and even a civilian expanded functions dental assistant or an EFDA, they are also trained. It's not as long as the preventive dentistry specialty program. I will preface that, but there are both civilian and military dental assistants that are performing basic prophylactic services on these service members and these patients. It's important to know that full mouth perio charting is not part of standard of care when it comes to military service members. They receive the PSR, which, if anybody who's attended a CODA accredited program, that is not standard of care and is used just for screening, but that is what the service members receive when they have their annual exam. So the scope of practice for a preventive dentistry specialist falls between PSR 0 to 2. And within that, if there's radiographic calculus, they're still supposed to be pipelined to a registered dental hygienist, but that wasn't always the case, unfortunately. So procedurally, I did a lot of adult prophies. If the patient had fallen out of my scope of doing an adult prophy, they received a full mouth debridement and then were supposed to have an additional appointment with the RDH. And then moving forward with that, if a patient was deemed an RDH prophy, they were supposed to be pipelined to the RDH from there on out, but that didn't always happen either. And then, of course, oral hygiene instructions, which were very limited compared to what I learned through a CODA accredited program, application of fluoride varnishes, and then the application of pit and fissure sealants. That was basically the scope of practice for me when I was in the Army. And then abbreviated, because preventive dentistry specialist is such a long word, the ASI or skill identifier number for the job was called X2. So if I say X2, I mean a preventive dentistry specialist.
Okay, I will call it an X2. I don't know
Perfect.
why it's so hard to say preventative dentistry specialist. Wow, so the course that you did was 12 weeks and then you were doing prophies.
Yes. And so I will say it's very structured. The program itself is taught by registered dental hygienists, and there is a supervising dentist over the program. So I will say it's probably a little bit more in depth than some of these weekend crash courses and OJT pathways, but that still doesn't necessarily make it okay. So the 12-week program, it's essentially 6 weeks of didactic and 6 weeks of straight patient care. And of course, you have 3 to 4 hours per patient because you're learning. And then when you funnel into your dental clinic after you graduate the program, you're supposed to ease your way into a full book of patients. But unfortunately, my first day as an X2, an RDH had called out and I had to take over her book of patients. So not only did I not have a funnel in process of having time to get faster with my skills or even just do something within my scope of practice, I had a whole book of RDH patients that I had to see as an X2, and they just all got debridements that day. It was 8 patients. So, luckily at the time, it was 1 hour per patient, every single patient, and that just streamlines the process with scheduling patients in the military. It's really hard to actually get more time unless there's a designated block for SRP, and that would be 2 hours, just because their model doesn't really afford for anything 90 minutes or anything like that. It's just 1 hour blocks at a time. But then I'll preface, I did X2 work my last 5 years in the military. My first 4 years, I was a dental assistant. During those 5 years as an X2, those appointments kept getting shorter and shorter. And by the end, it was a staggered schedule where you had 40 minutes per patient. And it just one, wasn't enough time, but two, also with just very limited scope and ability. That's where there was a lot of pressure. And that's my fear with this, of doing this into the civilian population. There's just a lot of pressure to produce.
Yeah. I mean, it's like we already have that even without a model like that. There's already so many offices that are doing shorter recare appointments, and I think ultimately the person that suffers the most is the patient, in my opinion. But so after you did this 12-week program and then you practiced as an X2 for 5 years, then you decided you wanted to become a registered dental hygienist. Is that right?
Yes.
Okay.
So it was probably halfway through my 5 years as an X2 that I realized I was not going to do this much longer in the military. One, I was using military benefits to put myself through college, and with constant government shutdowns, my education benefits weren't always guaranteed. So that was playing a factor in it. But then also, there was a lot of pressure from the administrative side to with production and readiness. So that's their metric, is readiness, which is the deployability of your patient population. And that is in terms of if they have no treatment needs, if they have treatment needs that will not turn into an emergency or expected to turn into an emergency in 12 months. So those two is class 1 and class 2. And that's considered deployable. So essentially, that's the goal. So if somebody came in and they had a large cavity or they needed a root canal, something that is foreseeable to be an emergency in the next 12 months, they are considered non-deployable. And then also, if their exam is overdue or they've never had one, they are considered non-deployable. So the goal is to get them into class 1 or class 2 category. And that also means they might not get a cleaning. So if they're class 2, they're still deployable, but it still says they need a cleaning. Or say they were in my chair and they really needed to see the RDH, they had the full mouth debridement, they're still class 2. So they don't need an appointment. And then from the leadership side or the administrative side, instead of giving that service member another appointment that could essentially prevent perio or prevent further bone loss, they would say that appointment needs to be given to somebody else who is class 3 or class 4, and do what you can, and we'll pick it up next year.
Wow. So how frequently would you be seeing like recare patients?
So the recare interval is annual. That's another issue as well, just with the patient population, is everybody's moving around. You're not really guaranteed to see the same patient year after year. If you saw your name in their chart, it was almost a celebration that you saw them the year before or 2 years before. But the military life cycle, people are moving from base to base every 3 years, sometimes 5 years. But then on a staffing side, there's staff turnover as well, because a lot of the providers that were civilians are usually military spouses. So their spouse leaves, they leave. So there's a lot of turnover. So there's not a lot of continuity of care where you get to reevaluate that patient again.
It seems like it's kind of missing the prevention aspect.
Oh, absolutely. So in Army Preventive Dentistry, prevention is in the name, but the system itself can't support that. There's just no way to support that with the rapid turnover of patients and providers. In the article that I wrote, one of the regulations I cited was the preventive dentistry regulation, and it basically says the mission is readiness. So even if they're trying to use preventive models and preventive tactics, it's just not built. It's almost set up for failure in that sense.
Since you went from practicing as a X2 to then a dental hygienist and going through a CODA accredited program, how did you feel like in comparison as for like all of the things that you learned?
Looking back, the big thing that I always say to people is you don't know what you don't know. So going through the 12-week program, I thought I knew it. I thought I was good. I wasn't taught how to scale and root plane. And I will say ignorantly, I was like, well, how hard can it be? And of course, we know scaling and root planing is uh it's quite challenging. And I work in perio now, and I still say SRP is quite challenging. But that is a mentality with a lot of X2s. I'm in communication with an RDH that she took me under her wing when I was an X2, and she taught me so much and just made me the best clinician I could be with my capabilities. But there are so many X2s that refer to themselves as hygienists. And the patients don't know. The patients don't know who they're seeing. And that's the same in the civilian sector. We hear it all the time where patients think that we're the assistant or the hygienist is the one that assists the doctor. And it's just they don't know. You don't know what you don't know. So from going through a CODA accredited program, I would say the patient interaction part was very easy for me. And I think a lot of people probably would say patient interaction is easy if you have experience in the field. You're a little bit more comfortable interacting with a patient, asking questions, communicating with them. And of course, scaling I had a leg up because I was taught how to scale, but I wasn't taught proper angulation techniques and insertion strokes and scaling strokes. I was taught how to scale with universal curettes and sickles and a cavitron. Um,
Oh, that's what I was going to ask if you were using, some type of ultrasonic or if it was within your scope to use that.
Yes, and that patient population in the military being seen once a year, you everybody got the Cavitron, every single person. And then even with that, I always had the power straight up and down. And now understanding the frequency, I have it 20 to 30% power at the most, unless I'm doing SRP with anesthesia. So I just felt like we were doing pressure washing services just to
Mhm.
flush all the visible calculus out of there. And in the program, you are taught to scale subgingivally up to 3 millimeters, but it wasn't anything that was required, if that makes sense. They said if you felt comfortable doing it, you could do it. But if not, that's where if there was radiographic calculus to go to the RDH.
I was a dental assistant or a registered dental assistant for 8 years, and I had the same mentality. It's like you said, you don't know what you don't know, and I worked at a lot of offices that actually didn't have hygienists. And so, my perspective of it when I did kind of just see what the hygienist was doing throughout the day, I thought the same exact way. Like, Oh, that's a piece of cake. I can do that all day long. Like just yesterday, I did an SRP, and at the end of the day, I was done. I was like, I am so tired and my hands on fire. And so you definitely gain respect for the practice of prevention and treatment of perio once you get in there. I remember being in dental hygiene school, and the first semester they start taking out instruments, and you have to be able to identify like which side is the right end. And I was mind blown. I was like, I don't think I can do this. I was like, I had no idea that I was going to be having to know every angle of an instrument. Like that was so crazy to me. So I definitely relate to that, just being an assistant for that long and going through dental assisting. My dental assisting program was 1 year, and I feel like, I did learn a lot being a dental assistant, but I still did not know everything that I know now going through dental hygiene school. And I just think it's so much different once you go through that whole process and learn all the things that we do about perio.
Exactly. And one thing that sticks out more and more is we weren't even taught basic tooth morphology in this program, and that is so important on a fundamental level to practice as a dental hygienist or even as a practitioner working subgingivally. You have to know fundamentally what it looks like or what textbook it's going to look like. And of course, there's variation, but that wasn't something that was taught. We were taught the tooth numbers and the different types of teeth, but I don't know how many papillas were lobbed off,
That's what I was gonna say. I was
essentially.
like, there's gonna be some hacked off papillas for sure.
Yes, there is that provider that is working outside of their scope and they don't know what they don't know. And they're like, yeah, I got this.
Sometimes too, when we are scaling, like there is so much inflammation and bleeding that you can't even see the tooth.
Mhm.
Like the SRP that I did yesterday, like you just have to, like you said, know the fundamentals of anatomy of a tooth, of a molar, and kind of your tactile sensitivity like takes over and everything. But that's not something that like you just pick up and, learn so quickly.
Yeah, I agree. And I work in perio now and I'm still learning something new every single day. This was in 2013 when I graduated X2 school. So this was 12 years ago. 12 years ago, I was like, yeah, I got it. And now, as an experienced clinician, as a professional, I don't have it. I'm learning something new every single day. But the big difference is in those short programs, it's a fire hose of information for one. It barely grazes the top of essential things that you need to know just to work in dentistry as a whole, but working alone with a patient and providing those services.
The thing that I really think about when it comes to these shorter programs is scaling is part of it. It's a quarter of it. It's if that, there is so much that goes into the conversations that we have with patients about prevention and about oral systemic health. So I'm talking to them about pregnancy and perio, and I'm talking about diabetes. And that's not something that you just learn in short condensed course. You can't, there's just no way that you can learn that information. And I think that when we talk about there being a shortage of hygienists and needing to have care for patients, we kind of miss all of that. And we just go straight to, okay, the cleaning part. How can we teach the cleaning part? But it's like, what about literally everything else?
In these shorter programs, you're taught the basics or a skim of everything that you need to know, but you are not taught the why. Why are we doing this procedure? Why are these oral hygiene instructions relevant? Why is the medical history review and understanding your patient's comorbidities, why that's important? And in the military, the patient population is relatively healthy in the sense that they are not running around with uncontrolled diabetes, uncontrolled hypertension, but there are unhealthy patients in the military population, but it's nothing like the civilian sector. And that is what scares me with these alternative certification models or scaling assistant models is there's no way to prepare somebody to understand the why we're asking these questions, why we are providing these services, why we are educating. I think anybody, in a sense, can learn how to physically do something, but understanding the mental aspect of it and the fundamental part of why we do things, I think that is just not a way that these programs can, I don't think these programs can teach that. I go back and forth with even thinking about this a lot. I still see veteran patients through the VA, and there are so many patients where I just think if they were in my chair 12 years ago and they weren't able to get the extra care that they needed, that they're in my chair today with perio, undiagnosed perio or underdiagnosed perio, or they were never educated or made aware of their oral health condition. Because a lot of the time in the military, it's just, I hate to say it, was debride and buy. Clean it, send them on their way. So there wasn't an educational aspect to it. And I was guilty of it. Just get them in and out, get them in and out. And then it gets to a point where you realize like this is not quality care. This is not doing a service to the patient. But there are so many veterans that are in their late 20s, early 30s, up till, 60, 70, 90 years old that they have so many instances of periodontal disease. And could that have been prevented while they were still in the service if they got the appropriate care that they actually needed? And unfortunately, I would say the closest population that translates to in the civilian sector is the Medicaid. It's the closest form in the United States to a socialized medicine model where the patients aren't paying for their services, they're not paying for it at the point of service, and there's not any revenue generated per se because there's no payers. It's just funded by a budget basically through tax dollars. So it's the closest thing to a socialized medicine model. And take that for better or for worse, that people are getting care at no cost, but then the trade off is they're not getting the frequency of care that they need.
Do you feel like there is like a type of model that is different in some ways that you could see being implemented? Like maybe something a little bit, I don't know, longer or more testing or something like that, that you would feel like, okay, that I could probably get in support of if it's like maybe somebody that can actually just see prophies and do that prevention service?
In a perfect world, of course, but my fear is, especially with growing pressures to produce because insurance reimbursement, for one, and not bringing in enough revenue due to overhead costs, salaries. So, doing an accelerated model, bringing somebody in who could do half the capacity or half the scope of practice as a registered dental hygienist, how far are they going to be pushed beyond that scope or to the limitation of the scope where it just basically becomes a moot point? And it's very frightening. And dentistry compared to healthcare is very unique in that aspect because dentistry is so underregulated. But think about it in a hospital system. You wouldn't have an LPN doing RN duties because there is such a risk for litigation, just like you wouldn't have an RN doing a nurse practitioner's job. There is strict regulations, regulatory bodies that are over medicine, but not as much in dentistry. And it's a double-edged sword. We could be overregulated, but I feel like dentistry is severely underregulated. But back to some sort of model, I was asked this recently by Bethany Montoya. In some states, they've passed this foreign dentist model to funnel into being a hygienist where they take an exam. And I don't necessarily agree with that because there are so many countries that don't recognize periodontal conditions. They're not taught anything to do with perio, scaling, or anything like that. And I also think it's disrespectful to the hygiene profession to kind of act like it's a step down, like, oh, you are a foreign trained dentist, either go to dental school here or take an exam to be a hygienist. And it's not like that in medicine either. If you're a foreign trained doctor, you still have to go to nursing school. It's not a step down, it's a completely different profession within the profession as a whole. So I would think maybe an accelerated hygiene model for foreign trained dentists, where it's not a full 2-year program, maybe a year. Just like with foreign trained dentists, their dental school is accelerated for 2 years instead of 4, or however long it is, where they are taught that specific scope that we do as a registered dental hygienist instead of just having a set amount of experience taking an exam and now you're licensed and it's not through an accredited or certified body. So I think that model should be something that's explored, but just as a whole, I think it just needs to be easier for hygienists to have licensure in multiple states. And I know the compact is working its way through and it's happening in some states, but other states are pushing back on it so hard. And the thing that is most disheartening is states that are refusing to join the compact are the ones that are pushing these lower standard models to practice dental hygiene.
Yeah, I feel even if some of these states like pass these more condensed programs and that I feel like it just is going to be this trickle down effect and the one of the root causes being negative work environments, toxic work environments, not being given the proper equipment to perform what we need to do. That is one of, the one of the foundation of why we're at where we're at. And if that's not getting fixed, then you already have dental assistants that are also leaving the profession and don't want to be here. And then you're creating this alternative role and they're going to get in it and they're going to be in the environments that we've been put in. And I feel like they're going to leave again and it's not really going to sustain itself like long term. It might be a temporary fix for some practices that utilize it, but long term, I don't really see it working and I don't think it's with like the best interest of with the patient in mind.
I agree wholeheartedly. Um, my fear is exactly the same, and a term that um, I refer to it as, or most people refer to it, is that it's bottlenecking. So we're at this make or break point where there's so many shortages as a whole, not just in dentistry, but we're trying to find different ways to offset this by picking from other areas that have shortages, which is going to create more of a shortage in the place that we're cherry picking from essentially. But with the negative workplace environment, so what's the incentive for somebody to want to get that training and possibly make a few more dollars an hour just to be even more overworked and underappreciated?
I don't know what the future holds, but I do feel like things are pretty quiet right now and it's kind of eerie.
I agree.
I'm like, it's been a little too quiet for a couple months now, and I feel like something is about to happen. But thank you so much for being on the podcast today and sharing your experience in the military and also just your insight and valuable stories about how it was for you when you were there and what you see moving forward for dentistry and prevention.
Thank you so much for having me.
All right, guys, this is the Brush with Britt podcast. Until next time.